Good morning. Hello. I don't know if folks online can hear the background noise. It just means it's nice and full. It's lovely to see Classroom D filling up slowly again. So welcome. And before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So in our ongoing series of medical grand rounds, highlighting our new professors, we are highlighting one of our recent promotees, Dr. Sergio Zepeda-Gomez. So Dr. Zepeda-Gomez completed his internal medicine, GI, and therapeutic endoscopy in Mexico City. He completed further advanced therapeutic endoscopy training at St. Mike's in Toronto. He joined the U of A Gastroenterology Division in 2011. His main areas of expertise include endoscopic mucosal resection, pancreatico-biliary diseases, balloon-assisted endoscopy, endoscopic treatment of Zenker's diverticulum, and enteral stenting for malignant and non-malignant strictures. Lots you can do by endoscopy now, right? He developed a smartphone app to track endoscopy numbers and skills progress among all endoscopy trainees that is currently used by more than 400 trainees in Canada and around the world. He has more than 40 publications, mainly in therapeutic endoscopy, and he's the director of the endoscopy unit and the advanced therapeutic endoscopy program, training program. He's also co-director of the small bowel endoscopy program. So I'm going to hand it over to you, Dr. Zepeda-Gomez.
Maureen, it's an honor to be here, an honor to be part of the university. I'm very grateful for that. And I chose this subject because, let me see if I can advance the next slide with the objectives. There you go. Because I think we, the university, have the largest small bowel program in the country. We perform a lot of small bowel endoscopy twice a week, and sometimes more than twice a week. And we get referrals from different, from all the province and also from other provinces, Northwestern Territories, Manitoba, Saskatchewan, sometimes from BC. And we are the only place in Western Canada that performs double balloon ERCP. However, that's a subject for another talk. And the other is maybe that was one of the reasons that why I was recruited here to the University of Alberta, because I have skills in double balloon that, and I was trained for double balloon in Toronto in 2005 when this technology was very new. And when I was there, I realized that the only place outside Japan that performed double balloon that year was St. Michael's Hospital, and I was doing that procedure with Gary May. So I realized that I was the only person with Gary May outside Japan doing this procedure, which was nice, but also a little shocking. And then I went back to Mexico, and then I came here. So these are the objectives of my talk. I don't have any conflicts of interest. And to put this in perspective, in the past, before double balloon and videocapsule endoscopy, it was very challenging to, evaluate the small bowel. We were having just indirect measures, and we sometimes found something. We didn't know exactly what it was. We didn't know what to do with that. Patients had empiric treatment for it sometimes, or the wrong treatment, and delay in treatment. So it was very challenging, and sometimes patients ended up in intraoperative enteroscopies, which were the only way to see the mucosa of the small bowel in its totality. And if, we found something during this procedure, the patients ended up obviously with a small bowel resection, which is sometimes not ideal if we can, do something else. And you may be asking, why don't you, just make a scope that is like 5 meters in length to evaluate the whole small bowel? With our current scopes, we can do a push enteroscopy and go to the proximal jejunum, but we cannot do or make a scope that is 5 meters long and evaluate the whole small bowel, because the small bowel is not a fixed organ. It's pliable, and it's just loose in the abdominal cavity. And if we apply forces into the scope, then what is going to happen is we're going to cause damage in the mucosa of the small bowel, because it's going to form a loop and the scope will never advance, right? So it was very challenging, but in 1997, we have, CT enterography was first introduced, which was a big step in the evaluation of the small bowel. In this situation, for example, we could, if a patient was bleeding from an arterial source in an arterial phase of the CT enterography, we can identify, for example, a Delafoy lesion. In the enteric phase, we can see better and characterize better polyps or tumors, in this case, a neuroendocrine tumor. And in the delay phase, if they were bleeding, we could find angiodysplasias, but if they were actively bleeding. And also, again, this is not direct visualization of the small bowel yet. And in the year 2000, finally, this was published in Nature as a brief communication. Gabriel Edan from Israel started to work in this. He's not a physician, by the way. He's an optic engineer, and who, by the way, had a friend who was a gastroenterologist. And around the 80s, his friend said, hey, why don't, we have this problem in gastroenterology. We cannot see the small bowel. Why don't you work on that? So he started to work on this in the 80s, and he started to test, different little cameras, CCDs, the light sources, the material. Obviously, this had to have the capability of transmitting the images or to store the images. And so he worked for 15 years on this until he came up with this system. At some point, they thought about putting a string on a camera, make the patient swallow the string and wait like 8 hours, right? And then pull the string out. The string had to measure about 5 meters, okay? And then they were like, well, maybe that's not a good idea, right? Also because it's dangerous, right? If you start pulling, something that is deep in the small bowel. So this is maybe why it's called wireless capsule endoscopy, right? So now the capsule looks like this. It's 26 millimeters in length, and these are the components of the capsule. It has an antenna, and in the past, the capsule stored the images and the patient had to retrieve the capsule. Now, it has the capability of sending and transmitting these images to this device, to a monitor that the patient attaches to himself or herself with a belt, and then all the images are stored there. The patient goes home and then comes back the next day, and then we can download all the images into our system. And then after that, we review the images in our computer. And as you can see, there is a timeline here, and we have also anatomical landmarks like the duodenum and the cecum, and that way we can have a very good idea of where the lesions, if we find something, is located in small bowel, and then make a decision about what route to take if we want to do something else like a double balloon enteroscopy. The other way to deliver the capsule, as opposed to swallowing the capsule, is by endoscopy. So we can attach this device to the gastroscope and then go into the duodenum and release the capsule there. So this is especially important in patients that are hospitalized, because these patients will have problems with swallowing or problems with delayed gastric emptying for many reasons, multiple medications, multiple comorbidities. So it's better, in our opinion, we do this here at the university in every inpatient, to deliver the capsule in the duodenum and then avoid the problem of capsule retention and an incomplete examination, right? So those are the two ways to deliver a capsule, and then we review the images. And then very short after this, after the capsule development, in 2001, Dr. Hironori Yamamoto published this paper in gastrointestinal endoscopy. He also had been working in a way to perform a complete examination of the small bowel with therapeutic capabilities, because biocapsule endoscopy is only diagnostic, right? So he came up with this incredible idea, simple but very smart, of a scope, an enteroscope, which is 200 centimeters in length, and an overtube that goes over the scope, both with a balloon attached that can inflate and deflate, And he performed this procedure in 4 patients. In the first 3, he found the source of bleeding and a stricture just 30 and 40 centimeters from the ligament of Treitz. But in the 4th patient, a 69-year-old patient that had a Meckel's diverticuli, he did a complete enteroscopy, which was the first time ever that somebody could perform this with a scope. And the reason why he was allowed to do this, it's because the system, as I mentioned, is very simple. We advance the scope and the overtube as far as we can in the duodenum. Then we inflate the balloon of the overtube, advance the scope, inflate the scope balloon, deflate the overtube, and then we inflate both at the same time when they are close together, and we pull the overtube and the scope back. And this way, as you can see, the small bowel is straightened, and we avoid the formation of loops, and we continue to do the same procedure over and over and keep advancing. Now, we do this, and we can advance a lot, not all the time to the second, of course, until we find the source of bleeding or the lesion that we're looking for, and we can do this by the oral route or the rectal route. So this is, how double balloon works. If we don't find the lesion, for example, by one route, then we go the other route, and the next day or the next coming days to complete the examination of the small bowel. So and this technology has evolved, obviously, over the last 20 years. The images that the double balloon delivers now are high definition, and the channel of the enteroscope is bigger, so we can do much more therapeutic interventions nowadays with this system. So there's multiple small bowel diseases. These are the more common and the ones that we face more here at the university. Vascular lesions, inflammatory bowel disease, neoplasias, strictures from many sources, patients with celiac disease or advanced celiac disease also, and polyposis syndromes. All of these conditions can present in different ways, but especially small bowel bleeding is the most frequent one. The other presentation, of course, is abdominal pain or signs of pseudo-obstruction or total obstructions. So based on this, the indications for a video capsule endoscopy are these ones. When we suspect that somebody is bleeding from the small bowel, suspicion of Crohn's disease, or when Crohn's disease is already established, to do follow-up or response to treatment, suspicion of small bowel neoplasia, usually when we have abnormal imaging and we want to do small bowel examination, suspicion of advanced celiac disease in the form of jejunitis, adenocarcinoma, lymphoma, and in patients with polyposis syndromes like Peutz-Jeghers syndromes, we want to stage the patient and see if there are big polyps, and then we can go after them if we find big polyps in the small bowel. Okay? By far, the most common indication is suspicion or suspected small bowel bleeding. Sometimes we cannot do a video capsule endoscopy, and this is especially true when we suspect that the patient has a stricture in the small bowel, because the capsule will be stuck in the small bowel. And this is especially true in patients with high suspicion of inflammatory bowel disease with an obstruction, on patients with chronic use of NSAIDs and abdominal pain, or patients that have had abdominal radiation, which have a higher risk of strictures in the small bowel. So in those cases, we prefer to start with a CT enterography to rule out or confirm a stricture. And then if there's no stricture, then we can go ahead with a video capsule endoscopy. So in patients with small bowel bleeding account for about 5 to 10% of all cases of GI bleeding. And this number is increasing because patients have more comorbidities, they live longer, they are on multiple medications, and those patients are at higher risk of bleeding in the small bowel. So this is increasing. And the typical scenario when we see a patient that we suspect is bleeding from the small bowel is the patient comes to emergency or to the hospital with signs of upper GI bleeding, like melena, hematochezia, sometimes maroon stools. And the first thing that we do after resuscitation of the patient is a gastroscopy. Then when this gastroscopy is negative, the next step will be, and this is done everywhere, all over the world, a colonoscopy. And the colonoscopy is usually done 24 hours later, right? So because the patient has to be prepped, and so we are, doing this over time, over a few days. And if the colonoscopy is negative, then that's when we are like, okay, maybe this patient is bleeding from the small bowel. And we have then two options, right, for investigations in the small bowel. One is video capsule endoscopy, and the other is CT enterography, right? So that's when we say this patient has suspected small bowel bleeding. This is the new terminology. We have patients, those patients can also present as so-called GI bleeding, which means that this patient has iron deficiency anemia. Patients with suspected small bowel bleeding and patients that have overt GI bleeding and negative gastroscopy and colonoscopy. And the new term for patients that don't have any evidence of GI bleeding in the small bowel after small bowel investigation is obscure GI bleeding. Okay, so this is a new proposed terminology, and it's what we use nowadays. And the patients with suspected small bowel bleeding can be divided in three subgroups. Active overt GI bleed, which are patients that are actively having bleeding in form of melena, within the last 48 hours. Inactive overt GI bleeding, they have had overt GI bleeding, but stop at least 48 hours before. And occult GI bleeding, which means no bleeding, no overt GI bleeding, but anemia. And this is important because the diagnostic yield in these patients is different. If we have a patient with active overt GI bleeding and we do investigations right away, the diagnostic yield is very high, as opposed to, for example, occult GI bleeding. And because of this, it's important to do everything right away. For example, a video capsule endoscopy, which will be the next step in management or evaluation, should be done within the first 3 days of a patient of the presentation. As you can see, the diagnostic yield within the first 3 days is significantly higher as opposed to after 3 days of admission, and also therapeutic interventions. This is also true for therapeutic interventions. And this has been confirmed in multiple studies all over the world. So the message here is timing is very important when we suspect that somebody is bleeding from the small bowel. And what are the causes of small bowel bleeding? Well, multiple societies in gastroenterology all over the world and associations divide the etiologies according to age. There are multiple etiologies, rare causes here, but the most common are here. And a simple way to do this is divide under age 40 and over age 40. Under age 40, the most common cause is inflammatory bowel disease. And over age 40 is vascular lesions. However, Dr. Omiya from Japan developed a comorbidity index. This is a weight index of comorbidity where you assign the score to one of these comorbidities, a weight for every disease. And according to this, if you have a patient with the Omiya index of 2 or higher, these patients will have 50% or higher probability to have a vascular lesion as the cause of GI bleeding. And if you add the age, then this is even better, because if you have a patient less than 50 years old with a comorbidity index more than 2, then instead of inflammatory bowel disease, the most probable cause will be a vascular lesion as the cause of GI bleeding. So this is a very helpful index that we use also to evaluate our patients with suspected small bowel bleeding here. Now, there are two options when we perform a video capsule. It can be either positive or negative. And that means that we have to evaluate the capsule. And when it's negative, we use the Sorin classification for small bowel lesions. For example, this is a normal video capsule endoscopy, and this corresponds to lesion type P0, so no bleeding potential. But sometimes we see little red spots and in the intestinal mucosa, isolated or small. These have uncertain bleeding potential. This means maybe these are not or have ever bleed. But when we see a P2 lesion, like fresh blood in the small bowel, a vascular lesion with active bleeding, an ulcer, or a tumor with an ulcer, this is a P2 lesion which has a high risk potential, right? So now we have these two options. When the video capsule is negative, we prefer to do a CT enterography. because there are areas that the video capsule endoscopy cannot see. In the ligament of Treitz, for example, patients with altered anatomy, and sometimes the capsule does, weird things, turns into itself, and then or travels very fast, and we can miss some lesions. So we prefer to do a CT enterography even if the video capsule is negative, because there are lesions that the CT enterography can see that the video capsule can't, and vice versa. So these are complementary studies. This is what I'm saying. And if patients have a negative CT as well, and they are stable, and they didn't have overt GI bleeding, they have a very good prognosis, and we can observe them, follow up, and then also give them IV iron. They have good prognosis. And if the CT or the video capsule are positive, then we move to balloon-assisted enteroscopy. And with balloon-assisted enteroscopy, we have many options of treatment for hemostasis, sclerotherapy, clips, injection, argon plasma coagulation, for example. And the thing that I said about timing with video capsule endoscopy also applies with double balloon. When we have a positive video capsule endoscopy or CTE, we need to do a double balloon or a single balloon enteroscopy as soon as possible. As you can see here, within 72 hours of recent overt GI bleeding, the diagnostic yield is higher than more than 72 hours, therapeutic interventions as well, and also change in management. And we confirmed this here. We published this last year, our group, and we also divided these patients into the 3 groups of suspected small bowel bleeding: the active overt, inactive overt, and occult. And we found, again, that the patients with active overt GI bleeding have a higher diagnostic yield as compared to the other 2. And also, we found and confirmed that when we do this procedure within 72 hours, the diagnostic yield is significantly higher, right? And this is an example of what we do here. Sometimes we put a cap at the tip of the scope, we advance, a video capsule in this patient was positive, and then at some point in the small bowel, when we go through the oral route, when you see fresh blood, that's when the point of bleeding is. We don't have to prep these patients. And the next challenge here is to clean everything, and because as you will see, this is a patient with a very tiny lesion that is constantly bleeding, a vascular lesion. So we need to wash. We use the cap to be more stable. And finally, when we find the little source here, then we apply treatment. We prefer to do, in these cases, hemoclip treatment, or sometimes combine treatment with APC. In this case, we put clips. Usually we put more than 1 clip. And usually in these cases with single lesions in the small bowel and after treatment, patients have a low risk of recurrence. Okay, so that's that. This is another video. This was seen by Dr. Halloran, actually. And as you can see, active bleeding in the small bowel. And in this case, Dr. Halloran preferred to do APC first, which is another method of therapeutic endoscopy. But after that, after this, he placed clips as well. So we want to also, place hemoclips in these patients. This patient was a young patient that had multiple episodes of bleeding and seen multiple times in other facilities with gastroscopies and colonoscopies until somebody said, oh, maybe this patient needs investigations in the small bowel. So he had 18 years old, and we went directly into the rectal route because we had high suspicion of a McLus, and this was a McLus, but a special type of McLus because it has intussusception and it was inverted. So we injected a tattoo for the surgeon, and then the patient went to surgery and everything was fine. And this is another patient, not young, but old. And these are things that we can see in all patients, a high burden of diverticulosis in the small bowel. When we see an active bleeding, we can do something. If we don't see an active bleeding or a site where we suspect the patient bled, then we also have to inject tattoos in case this patient bleeds again. So they can undergo surgery, or sometimes these patients go to interventional radiology. So after we do treatment in the small bowel for bleeding, we need to evaluate the efficacy of our treatment. And usually we evaluate this with evaluating if the patient has recurrence of bleeding, the blood transfusion requirements, and the number of hospital admissions in the long term. And as you can see here, up to 40% of patients with small bowel bleeding can have recurrence of bleeding, but especially patients with cardiovascular diseases, specific aortic valve stenosis, patients with chronic renal failure, and patients with hereditary syndromes like hereditary hemorrhagic telangiectasia. These are the patients that have a higher risk of rebleeding. So these patients, we cannot be doing constant double balloons and do treatment because it's useless. So they need a different type of treatment. And in patients with aortic stenosis or that develop acquired bone bilirubin factor deficiency, the best treatment is usually transcatheter aortic valve implantation, or TAVI. Most patients, more than 50 or 60% of patients, stop bleeding after this, and also with surgical replacement of the aortic valve. And patients with other syndromes like hereditary hemorrhagic telangiectasia, for example, they usually undergo medical treatment, right? Like in the form of somatostatin analogs, thalidomide, and inhibitors of the vascular endothelial growth factor like bevacizumab. We have a few patients under medical treatment with HHD or with other conditions that will put them at high risk of rebleeding. And this is a flow chart of the approach of patients with suspected small bowel bleeding. This is something that we published in 2019. And something that is not here is patients with massive GI bleeding that are unstable. Instead of going through this route, they have to go to interventional radiology or surgery. Okay. So, do you remember this? This doesn't make any sense after all that I said, right? So, because I was saying that you have to do everything as soon as possible. And if we do a colonoscopy, we're just losing time, wasting time, because in these patients, if we do a colonoscopy, the chances of getting something positive is very low, right? Less than 5%. So this is what is done everywhere, but what we're doing here is after the gastroscopy is negative, we are trying to do an early video capsule placement. At the same time that we do a gastroscopy, if it's negative, we want to do a capsule drop. And we have this ongoing randomized controlled trial, randomizing patients with the traditional and standard guidelines going through a colonoscopy first, or early small bowel interventions with capsule. And I can tell you that the majority of patients with early video capsule interventions have mostly positive results, most of them except 2. And in the colonoscopy arm, only 1 has had a positive result. So we expect to finalize this hopefully this year and present the results soon. This will obviously change the guidelines if it's true what we are thinking. Other utilities or uses of small bowel endoscopy, it's in Crohn's disease. In suspected Crohn's disease or in established Crohn's disease for monitor the extent or an activity of the disease, evaluation of ongoing symptoms, or assessment of recurrence after surgery, and the treatment of small bowel strictures. Video capsule endoscopy can give us a very good idea of how patients with Crohn's disease, how active are they in the form of erosions, ulcerations, sometimes, even if we don't want to, strictures, and also double balloon enteroscopy, assessment of the mucosa. And when we find strictures, so this has volume. This is Dr. Halloran's video. So we see a stricture, and then if we cannot advance through a stricture, we do a dilation, and after the dilation, we usually are able to advance through the stricture onto the other side of the small bowel and continue the examination, because these patients usually have more than 1 stricture, right? So this is a publication by our group, mainly driven by Dr. Raymond Halloran, who is maybe the person in North America that does the majority of, or the most patients with, strictures in Crohn's disease and dilation. And the proposal of the approach of these patients until they have dilation and the follow-up, the description of the stricture dilation. We showed that it's a very effective method of treatment of patients with strictures in Crohn's disease, delaying surgery or avoiding surgery, and also better quality of life, and also with a very low risk of complications. No major complications were reported in these very large series of patients that were done with double balloon and single balloon Crohn's disease stricturing. And finally, regarding neoplasia and other lesions, we can do, diagnosis, biopsies, marking with tattoos, neoplasias, polyps, and celiac disease. Neoplasias, actually, primary neoplasias are rare, and it's more common to see metastases from other primary tumors than primary tumors in small bowel. In this case, usually, instead of doing a videocapsule first, we have CT enterography, and then in this case, for example, this was a lesion that we found in the small bowel, and then we performed a double balloon, and it was a gastrointestinal stromal tumor. And in this other case, another lesion in the small bowel that looked malignant, and it was confirmed to be an adenocarcinoma of the small bowel as well. And this is a video of a patient with lung cancer. This is a metastasis in the small bowel. In these cases, we take biopsies to confirm the diagnosis, and then we inject tattoos. If the lesion is isolated, those patients sometimes go to surgery. And sometimes patients with neoplasia present with bleeding. This is a patient that presented with massive GI bleeding in the mid-small bowel, and we found a stricture or a lesion in here with easy bleeding at air insufflation or CO2 insufflation. You can see completely abnormal mucosa with ulceration. And this is just by insufflate, this lesion started to bleed. Then we advance it at the end of the lesion, and you can see there is small bowel normal mucosa again here. So we were able to delineate the length of the lesion, and then we took biopsies. Somebody wants to make a guess? This is a B-cell lymphoma, and the patient didn't need to have surgery. He underwent chemotherapy, and we follow him with videocapsules, and he's fine. And this is just a flow chart about how to approach patients with suspected small bowel neoplasia. Basically, the same thing. If we don't suspect that there is a stricture, we go straight to CT enterography or videocapsule if there are no obstructive symptoms, and eventually we'll do endoscopies to confirm the diagnosis. In celiac disease, videocapsule is very useful to evaluate the extent of the disease and to evaluate for complications of celiac disease, like ulcerative jejunitis, T-cell lymphoma, or adenocarcinoma. And in polyposis syndromes, videocapsule, like I said before, we can stage the disease, and if we identify large polyps, we can go and do a double balloon and resect the polyps, only the ones that can cause intussusception or bleeding. And currently, we're working, like I said, in a randomized controlled trial of early videocapsule endoscopy. Also, we want to start a randomized trial comparing videocapsule endoscopy swallow versus endoscopic placement in hospitalized patients to hopefully show that endoscopic placement is better than swallowing in patients. Dr. Halloran is working on on-demand stricture dilations versus recurrent in Crohn's patients with small bowel strictures. There is a small bowel Alberta registry going on, and we have a collaboration with Dr. Yamamoto. We have had the honor to have him 2 times now, and he's coming again this year to visit us. We have a collaboration and exchange with them. Hopefully, we will continue for a long time. And finally, what is the future? For videocapsule endoscopy, patients now have to come 2 times to the hospital to have a videocapsule and then return, and then we read the videocapsule. In the future, maybe the capsule will be delivered to them when they start having symptoms, and then they will come here to the hospital to give us a monitor. And maybe in the not very long future, we will have patients with capsules at home. When they have symptoms and when they start bleeding, they just swallow the capsule and the images will go to a cloud. And then we will be in the hospital watching those images here, and then we will call them if they are actively bleeding or not, right? This is something that will likely happen in the future. And finally, I just want to thank the small bowel team here at the university. Is not only the physicians, Dr. Clara and Wasilenko, also we have a video capsule nurse, Margaret, our endoscopy manager, David Ayashinsky too, and our therapeutic fellows that read capsules and help us also with the procedures. Without all this team, we couldn't do this. And obviously, thank you to the Department of Medicine. Thanks very much.
A great story and amazing pictures,
Thank you.
sci-fi type pictures. So those were great. I'm just gonna kick it off if that's okay, and just ask you a couple of questions. Thank you for addressing the 72-hour, because those of us that look after these patients that come in with acute GI bleeds, and obviously, you know, going the gastroscopy and then colonoscopy, I mean, that's well over, especially the ones that come in on Fridays,
Yes.
is inevitable. But I just wondered if there is inclusion of some cost analysis there. I mean, I imagine that this sci-fi,
Yes.
you know, it's sort of imaging that you're able to produce, it must be pretty pricey. And so have you included that in there?
We haven't done a cost analysis study. I am assuming that the cost analysis, like the early intervention in small bowel, will save money because the hospitalization days will be shorter. And also colonoscopy, you know, costs, and it implies that patient will have to stay longer, another procedure. And if we find the source with early small bowel investigation of the patient, and we stop, for example, the bleeding, or we find the lesion, like an aplasia, then we will save costs because everything will be done more rapidly. Yeah, that's what I think. I don't know if there is a cost analysis study about this.
The cost of the capsules was $700, right? So it's not much.
Yes.
It's less than
Oh.
processing biopsies that are in pathology, right? So
just to be clear, the actual capsule is 700, but then there is the time. I mean, how many images do you get with a given?
Yeah, so the capsule take 4 frames per second. There's a lot of images, but our software help us, and then we spend in average one hour reviewing a capsule, I would say, yeah. And the software sometimes helps because it can identify abnormal areas, and we focus on those ones. Yeah.
And I imagine there's opportunity here for AI.
Yes. So there is already AI used in video capsule endoscopy. We don't have it here. In the future, maybe AI will do the whole review, and then we will just confirm that the AI is correct. But that's already been done in other places.
Well, I'm sure you already know we have a number of radiologists, just blanking on his name, who are looking, you know, doing a lot of work with AI and
Yes.
and imaging. So there's potential opportunity.
Yes. Yes.
Sorry.
Yes, no problem.
Congratulations, Sergio. That was an excellent roadmap. Now, the comment or question I have is we live in a day and age of the pandemic of obesity, which has led to alterations in GI anatomy.
Yes.
Multiple anastomoses within the bowel, which are beyond the reach of conventional endoscopy. Can you say a few words about where you see the role of small bowel imaging, video capsule, especially because is it an absolute contraindication? And if so, there's a lot of morbidity that we see with these kind of scenarios. How best would you approach?
Yeah, absolutely. That's a great question. Patients that have had bariatric surgery or Roux-en-Y surgeries, it's a relative contraindication for video capsule because the capsule can go to the biliary limb and stay there, and we cannot do a complete examination of the small bowel. So we rely more on CT enterography there. And if we suspect that, for example, in those cases, usually the problem, it will be a bleeding from the Roux-en-Y anastomosis. Then if we have a high suspicion and we have a CT that is inconclusive, but the patient is bleeding, we just go ahead with the neural double balloon and try to evaluate the anastomosis and also the biliary limb. It's a relative contraindication. In some places, they still do it, but it's not like very convenient because of the reasons that you are mentioning. Not just bariatric surgery, but after liver transplant, patients with Roux-en-Y anastomosis too, or Billroth twos. On those patients, the approach is could be a little different.
just online, we have Dr. Ross Mitchell, and he's just reiterating that there are powerful models. So I think it would
Yes.
be worthwhile giving that group a call
Yes.
to collaborate.
Yes, that would be great. Yeah, we'll be glad to collaborate with them.
Yeah,
Yes.
sure.
Sergio, I think the one thing that surprised me in your talk was that in the less than 40 group, that malignancy was higher than in the greater than 40 group. Can you comment on that?
You mean in the Omega index? Let's see.
I can't say that.
Yes.
We didn't see that much small bowel malignancy in general. I just thought it was weird that it was in the less than 40.
It's not, so in his original paper, there's not a lot of patients. Let me see what kind of, yeah, here. So in the less than 50-year-old patients.
So go to the next, the less than 40. I think previous.
Oh yeah, so okay, so this is interesting. Yeah, this is interesting because most gastroenterology societies, they do this. They say they just arbitrarily, without many, backup from evidence in the literature, they just mention, oh, neoplasia should be also a cause. But when you see what Dr. Omilla did, neoplasia is not in this age. You have to have a score higher than 4 for malignant tumors in age less than 50, right? So that's different than what the society tells you. So there you go. So in this age, it's more frequent. But yes, let's say this is why this is more important, to take into account all the comorbidities and age.
I'm just curious in terms of inflammatory bowel disease. I mean, I know given Brendan's practice and the amount of IBD that we have in our area. So am I correct in understanding one of the studies that you talked about, that you're talking about surveillance as opposed, or doing it based on symptoms as opposed to surveillance? Is there surveillance that goes on currently?
Yes, that's a very good question. I think, Brendan is the most experienced in this matter, but one thing is surveillance and one is on-demand endoscopy for symptoms. And this is what, for strictures. So when patients start having symptoms, then that's when we want to go and do dilation of those strictures. But what he wants to do is do a protocol where don't wait until they have symptoms. And then every 4 to 6 months, do an enteroscopy and keep dilating. And then the other group on demand, and then see the outcomes at the end, like which patients will not go for surgery, which patients will have more complications, which patients will have quality of life. And correct me if I am wrong, your theory is that with your protocol, like when you protocolize the patients, they will do better than on demand, right?
We don't know. I think so. And the question is, we for some patients, we use this ileal colonoscopy. So those patients are surveyed this way. So we're really aggressive in leaving mucosa unvisualized and not treating by surrogates, because these patients still do have malignant risk and other things. And surrogate imaging, no matter what it is, IUS, CTE, all these things are still surrogates, right? And the mucosa is actually treated. So we're pretty aggressive here, I think, and we have a lot more access to the places, but we use a kind of a ileal colonoscopy for people with extensive smoking. Yeah.
Well, that brings an interesting question. So you started the story by saying that, you were one of 2 who was doing them in the country. So how is that story developed? Do most large centers now do SBE, or what's
Yeah, so it's actually, I know obviously Toronto does double balloon, Calgary has double balloon, Vancouver has double balloon, and I think Montreal.
It's becoming more common. Like Ottawa had a program.
Yes, but not a training program. They perform, but we have the capability of doing training. We have trained fellows in double balloon. But obviously, sometimes it depends. Are you going to have that resource at the institution that you're going to come back? Right?
Yeah.
And it takes around 150 procedures to be Yes, competent in double balloon, single balloon. The technique, as you can see, looks easy, but you have to know how to troubleshoot. The patients that have different anatomies, so some patients are much more difficult than others. So it takes time, experience, and also it's not just to know how to do it, but also the therapeutic interventions, right? And when,
Yeah.
exactly.
Anything online? Okay. Okay, so with that, I just want to take this opportunity to congratulate the group and Sergio, and thank you for an outstanding
Thank you very much.
presentation.
Thank you.